Okay, I don't see the numbers ticking up too much more, so I think we can get started. For those who just joined, welcome. Please introduce yourself in the chat with your name, organization, and your location, and we appreciate it. Well, to start off, my name is Steve Serra, and I'm a senior WASH advisor with Save the Children, supporting the USAID Pro WASH Award. As many of you know, Pro WASH aims to provide support to implementing partners to strengthen the quality of WASH interventions through capacity strengthening, knowledge sharing, and applied research opportunities. This webinar is the first in a three-part series, and today's webinar is going to focus on a Pro WASH funded study to identify enteric pathogen exposure pathways for young children in rural Kenya. Before we begin, we want to make sure everyone knows that French interpretation is available for the webinar. So if you'd like to follow the event in French, where it says interpretation, you can just click on the small globe at the bottom of the screen where it says interpretation, and then select your preferred language. And once you've selected your language, you can choose to mute the original audio, or you can hear it in the background at a lower volume. If you have any technical issues during the session, please send a chat message to Pro WASH, and we will do our best to assist you. And please note that if you have any questions for the panelists today, please post them in the chat throughout the presentation. I will collect them, and at the end of the session, I will pose them to the panelists, and they can field the questions in order. Without further ado, I'll introduce our panelists and turn the presentation over to them. So first we have Lomanito Lamoro, who's a health system strengthening advisor with the USAID Nawiri project in Kenya. That is the project which this research is supporting. And he's going to give a brief overview of the Nawiri project to frame the reason why we did the research. And then we'll pass it over to Abby Harvey, who's, Matheson, can you advance the slide one? Thank you. Abby Harvey is a PhD student and part of the research team that conducted this research, along with colleagues at Innovation for Poverty Action, UC Berkeley, and NC State. And John Mboya, who's an associate research manager at IPA, an MPH student at UC Berkeley, and part of the research team. So I will turn it over to Lomanito, who will get us started with the core of the presentation. Thank you.
Thank you so much, Steve Serra, and welcome everyone. I'll take you through the program USAID Nawiri, just to give a highlight of what USAID Nawiri is doing and where its location and the strategies that we are looking through to attain the goal of reducing persistent acute malnutrition. So this project is a USAID funded project, 5-year USAID funded project in Kenya. It's located in the two northern counties of Turkana and Samburu counties, the semi-arid and arid and semi-arid lands of northern Kenya. This program is led by Masico in a consortium with Save the Children, Research Triangle Institute, local partners, Caritas Lodwar. We have FOMA and a research institute, APRHRC, in conjunction with the county government of Turkana, county government of Samburu, and the national government. This particular project covers the two counties of Turkana and Samburu, which has a population of more than 1.3 million. Next slide. So the projects USAID Nawiri looks at reducing persistent acute malnutrition sustainably in the two counties of Turkana and Samburu. And it has, to do this, it's looking at 4 purpose areas. the focus area, number one being that the vulnerable households within the two counties will be able to maintain food security despite exposure to stress and shocks. And food production particularly will be looking at enhancing vulnerable households do food production in terms of crop production, agriculture, livestock, poultry, fish, and access to markets. The second purpose area looks at the same vulnerable households being able to have a low disease burden. And this is basically through enhancing knowledge and practices around maternal, infant, and young child nutrition, ensuring access to healthcare services, as well as water, sanitation, and hygiene. The purpose area number 3 looks at a stable and resilient nutrition enabling environment. So we operate in the counties where culture, norms define the way of life within here, and the issues of gender dynamics hold so much in terms of household decision making. So that is also very important. And the purpose area number 4 is about formal institutions within the two counties being able to monitor, learn, and adopt so that we are able to prevent and respond to acute malnutrition. So the issues of governance, issues of data for decision making, use of the GIS all fall under. So we think, and we know that by applying through these 4 purpose areas, we will work together to have persistent acute malnutrition reduced in Turkana and Samburu counties. Next slide. Thank you. So here, I want to give highlights on the pathways that USAID Nawiri is using to have reduction in acute malnutrition. And our target population for this is about 471,000 people, 361 in the two counties. Remember, I talked about 1.3 million people being in the same, in these counties. And so the pathways of reducing malnutrition really focuses for us at the individual level. So if you look at the center of this diagram, you have a young woman and in her teenage years, and we are calling her Nasieku. And so most of the interventions, so we think most of the interventions should center around the individual, and so that individual, in interrupting the generational cycle of malnutrition, we will have different levels of the interventions. So all these pathways will either act at the individual level. There are those that influence at the household level, community levels, the systems, governance, and all this. So the government system, all this interplay helps us reduce persistent acute malnutrition. So we have done a number of studies that have helped us understand these pathways. And we've done about 12 studies. 2 of those studies are still ongoing. They are still ongoing, and they're coming to a conclusion. We have a study that looks at the systemic factors around malnutrition that is ongoing. And now here we will also have a look at a study that looks at the fecal-oral pathogens pathway and how it brings about malnutrition. So the fecal-oral pathogens pathway, how it brings about malnutrition. So we have here a number of, pathways that have been informed by the evidence that we did in year 1. We have, when we looked at, for example, the issues of food production. So we know that access to nutritious and diverse foods throughout the year, even in the face of shocks, are likely to help our Nasieku here reduce persistent acute malnutrition. But of course, access to care, their knowledge, attitude, and practices on nutrition and health, being able to access, afford healthcare services, and utilize those services is key. We're also talking about the decision-making processes at the household level, at the community level. Those structures enable, allocation of resources, the agencies to make key decisions that are critical in ensuring that there is either food or water or services for the household. So for us, that is also key. And this particular NASTIECO, their ability to make decisions over their own sexual and reproductive health is a pathway that we're also really exploring, and it's likely to have greater impact. So today, our focus will be what food contamination processes and water contamination processes lead to acute malnutrition. So we have all this evidence just to show you how the government, private sector, civil society, individuals can be able to prioritize, all these interventions from the planning stage to budgeting stage, so that then we can be able to reduce persistent acute malnutrition. Back to you, Abby and John Mboya.
Okay, thank you. Hi, everybody. As mentioned earlier, I'm Abby, and I'm a PhD student at UC Berkeley, and together with John Mboya, we'll be presenting our results of a study called Pathogen Transmission to Children Under 2 in Turkana South and Samburu North. So first, to look at the background and motivation, addressing malnutrition in young children is vital. Malnutrition occurs primarily between birth and 5 years of age, but the first 2 years of life in particular are vital to long-term child nutrition, cognitive development, and later health and educational outcomes. Research has found that forms of child malnutrition, such as stunting and wasting, that develop in the first 2 years of life can persist into adolescence and into adulthood. And wasting in particular is associated with child mortality. In particular, 1 in 5 deaths among children under 5 are attributed to severe wasting, and more than a quarter of those of all wasted children live in Africa. Wasting is particularly a problem as well in areas with conflict and climate shocks, such as droughts, which occur in Turkana and Samburu regions in Kenya. And so enteric pathogen exposure can also contribute to malnutrition for children. So while it's definitely clear that an inadequate diet can cause acute malnutrition, so too can child exposure to enteric pathogens, which are pathogens that affect the gastric system. And so if children are frequently exposed to enteric pathogens, they can become infected, suffer from diarrhea, and frequent infection can lead to an inflamed gut and an inability to absorb nutrients, which can contribute to acute malnutrition as well. So this study is really focused on understanding how specifically children are exposed to enteric pathogens through the environment. So enteric pathogens originate in human or animal feces and can be transmitted through the environment to the target children. So the research question of the study is, how are children under 2 in the Turkana and Samburu counties, Kenya, exposed to enteric pathogens? And our research objectives were to, 1, determine pathogen profiles of child fecal, soil, and food samples, which is still in progress and is not being presented today. We also aimed to longitudinally sample young children, those under 6 months, to try to identify their very first exposure to enteric pathogens. And again, that's in progress and is not going to be presented today. And then our third objective is to quantify E. coli contamination levels in household environmental reservoirs, and then identify the dominant exposure pathways, and in particular understand how these dominant pathways differ by child age. And then finally, we aim to recommend interventions for piloting in collaboration with the study community. Now I'll hand it over to Mboya.
Thank you, Abby, for the good background. I will go over the methodology sections, and then at some point later on, Abby will come back to present about the findings, and then I'll come back again and present on the recommendations. So to start with the study, so as Mark had said, Lominito had mentioned that this study was done in Turkana and Samburu, which are part of arid and semi-arid lands in Kenya, and they are majorly in the northern Kenya. And specifically, the study took place in Samburu North and Turkana South sub-counties. And most of the setup here is rural and low-income setting, consisting of pastoralist and agro-pastoralist communities with high livestock ownership. And one of the indicators here is that less than 5% have access to improved water, improved sanitation, and then there are high rates of GIT illnesses among children, with global acute malnutrition prevalence of 16% in Samburu and 26% in Turkana. Next slide, please. So the next slide here, presentation here, is about the methodology. How did we sample household and what samples did we collect? So this study, as Lominito had mentioned, this study was part of the larger Nawiri study. So we sampled a subset of 100 households from the larger Nawiri longitudinal study. And to do this, so in Turkana, we did 50 households. Samburu, we did also 50 households. And the eligibility criteria here was an household that had a child that was below 2 years was able to be enrolled into this study. We collected several samples to answer our research objectives, and we collected environmental samples, household fecal samples, as well as soil samples. So the environmental samples we collected here included stored water, source water, soil, food, hand rinse, and fomite. And then we collected the target's child stool samples or fecal samples, plus the caregiver's stool sample. Then we also collected animal feces for these particular samples. For the stored water, we collected about 250 mils, and for the source water, we collected about 500 mils, and soil, we collected about 150 grams. Food sample, we collected what was available, because some of the communities had less food for the complementary food for the child, so we did not want to collect a lot of samples and leave the child with less food. For hand rinse, we collected on the target child, and we collected on both sides, left and right hand side. So with this, we pre-filled a sterile a bag with the sterile water, and then just rinse the hands of the target child 15 minutes, 15 seconds, both sides. And then the fomite is an object that the child plays mostly with. It could be a bottle top. We also rinsed this in 250 ml sterile water and put all these samples into cooler box, given the temperatures here, just to improve the integrity and the viability of the samples before they are shipped to the lab, before they are transported to the lab. For child feces, we collected about 50 to 60 mils in a sterile tube, as well as the mothers or the caregivers' stool samples. For the animal samples, we hired and trained veterinary technicians who are locally or locals from those two counties to collect these samples. We collected fresh animal fecal samples within the compound. So if the animals were not within the compound, or animals had gone to graze, given the pastoralist nature of these communities, then we would try and go and follow up if we could reach where the livestock or the animals were grazing. If not, then we would just collect the most fresh fecal sample from the animals within the compound. and put into a cooler box. And for this, we also did some quality control checks and collected something we call field blanks, which could help us to check if there was contamination of the samples by the field officers during sample collection. These samples were later on transported to the local lab in Samburu as well as Turkana, and we did preliminary analysis to enumerate E. coli using IDEX method and most probable number method to quantify the E. coli. Some of the samples here we aliquoted and shipped to KEMRI for further analysis, which will be used to answer the two objectives that Abby had mentioned there that we are not presenting today. Apart from the sample collection, we also did structured observation where our field staff just requested the caregiver to allow them to do a 3-hour observation with a checklist and just count or enumerate or observe the behavior of the child. What are they putting into their mouth? When they are crawling, what are they doing? And just record that into our survey. Then we also did just general survey just to collect the WASH indicators on the child health, and then household demographics and the caregivers' risk perception about some of these potential pathways. Next slide. So Abby will take us through this, and then I'll pick up again on the recommendations.
Great, thanks, Mboya. So to move forward with some more of our methodology, as Mboya just mentioned, we collected samples in each household from all of the environmental reservoirs highlighted red here, with the goal of understanding and modeling transmission along each of these red arrows. And to do that, we're using quantitative microbial risk assessment, or QMRA. And so we use the E. coli concentrations that we measured in each of these sample types in the field, together with the child behavior. So for example, how often they're putting their hand in their mouth or consuming soil. And then we're also using parameters from the literature, such as the amount of food they're consuming or the amount of water that they consume as well, to model transmission along each of these pathways. Okay, so to move into our results, first, I just want to add the caveat that these results are preliminary. We're still doing some laboratory analysis, as Mboya and I have both mentioned, so the results could change after further analysis. Jump into some household characteristics. So we sampled 100 households between the two sub-counties, and we found that 0 of those households reported treating drinking water. Less than half had any type of latrine, and only 4% reported having any type of hand washing station. We also find that about 2/3 of the households are below the Kenya poverty line, and specifically below the Kenya food poverty line. Also, animal ownership was widespread. 86% of households reported owning livestock. There's also limited water access in the study regions. So 50 households reported using piped water, 36 boreholes, and the remainder a variety of sources. And while this isn't something we measured in our survey, just our enumerators' experience in the field suggests that the source of this piped water is, for the most part, boreholes. So the vast majority of households in this area are using boreholes for their drinking water. Also notably, 66% of these households reported that their source was not available when needed, at least once in the past 2 weeks. So 2/3 of the households reported experiencing this. In about half of those cases, it was because the source was out of water, and some number also due to a lack of fuel or electricity. So in total, we enrolled roughly equal number of children across 4 different age groups. So the age groups we considered were 0 to 2 months, 3 to 5 months, 6 to 11 months, and 12 to 23 months. And we selected these specific age groups based on US EPA data on child development and behavior. We also enrolled equal number of households between Samburu and Turkana, and we also ended up with a roughly even gender split. We asked caregivers to report what types of food their children consumed. So when we look at child food consumption by age group, we can see that in the youngest age group, the 0 to 2 months, they're almost entirely consuming breast milk. And then as the children age, they transition to consuming less breast milk and more of other different types of liquids, and then also transition into eating soft foods and solid foods. We also asked caregivers to report whether their child had experienced any diarrhea within the past 7 days. And so we also find a very high prevalence of diarrhea. Here I've shown the proportion of children whose caregiver reported they had diarrhea in the past 7 days. And so we can see that it's around 30–35% on average, and that this actually peaks in the 3 to 5 month age group. I'm going to transition now into reporting our E. coli results. So shown here is the proportion of samples that we detected E. coli in by the sample type. And so we find, first of all, these results are split by Turkana and Samburu. So the Turkana samples are in red and the Samburu are in blue. And so we find that the samples are more likely to be contaminated in Samburu than compared to Turkana. And that stored water is the sample most likely to be contaminated with E. coli. Here, these are showing the levels or concentrations of E. coli in each of the sample types. And so once again, split by county, we can see that in addition to being more likely to be contaminated, there's also higher level contamination in samples in Samburu North. We also find higher contamination in stored water versus the source waters, and relatively high levels of contamination in food. So as Mboya mentioned earlier, we also did structured observations to measure child behavior. And so displayed here are the hand contacts per hour of the children across the 4 different age groups we're considering. So we see that as the children age, the frequency of hand contacts is increasing. And there's also a transition from mostly contacting the caregiver to contacting more fomites and soils. Shown here is a similar plot, but now we're showing the mouthing behavior of the children. So this would be the number of times that they put an object in their mouth per hour. And so for this, the peak of mouthing behaviors is within the 3 to 5 month and 6 to 11 month age groups. And we also find pretty frequent mouthing of the child's own hands. We also recorded where the children were spending their time. So the options included inside the house, in the courtyard, in the field or bush, in an animal pen, or any other location. I do want to note that this data was collected roughly between 9 a.m. and 3 p.m. So this is only valid for this time period. We can't say anything about where children spend their time for the rest of the day. But what we can see in our observations is that the youngest children, those from 0 to 2 months, spend the vast majority of their time in the house. And as they age, they transition to spending less time in the house and more time in the courtyard. Okay, so now I want to discuss the results from our QMRA model. So here we modeled transmission along the various pathways. And we did this separately for each age group. So shown here on this plot is the daily dose of E. coli that children would be consuming according to our model. And we find that the children over 6 months are exposed to the highest E. coli levels. We also find that food is by far the dominant pathway for these older children who are consuming food. And then here I've just zoomed in on those younger age groups because in the prior graph, it may have looked like their exposure was 0. It's not 0, it's just much lower than the older age groups. But we find for these younger children that water and hands are the most important exposure pathway. So going back to the last figure with the daily dose by age group, I've also added to this figure the diarrheal prevalence by age group. And I did this because I just want to remind you that we found high diarrheal prevalence even in these younger age groups with the children less than 6 months, who, according to our models, have a much lower dose. So this kind of indicates that although their dose might be low, it's still important to their health, and they're still suffering from high levels of diarrhea. And then also, given our modeled E. coli doses, the infectious dose for many pathogens is plausible in even just 1 day of exposure for these children. I also want to highlight the differences that we saw between the two sub-counties. So here, this is the diarrheal prevalence by age group, but split out into Turkana versus Samburu County. And so comparing across the two, we can see that there are much higher diarrheal prevalences in Samburu, especially for the 3 to 5 and 6 to 11 month age group, than compared to Turkana. And we also did our QMRA modeling separate for each of the two sub-counties. And we find that in both sites, food is still the most important exposure pathway for the children who consume food, but that hands and water are relatively more important in Turkana than compared to Samburu. Okay, so now I've presented all of our results of transmission along these red pathways, and we find that food in general is the most important exposure pathway. So I think an important thing to think about when we're considering what recommendations to give are what are the current food hygiene and storage practices in these households. So we collected, as part of our study, 28 food samples, 9 from Turkana South and 19 from Samburu North. And we find of these samples that 46% of those, the food was stored uncovered, 43% the food was stored on the ground, nearly 2/3, 64%, the food was not reheated before serving, and 57% the food was cooled without a lid. We also had our enumerators observe the food preparation areas, and they observed flies present in 54% of the households, trash in 43%, and animal feces in the food preparation area in 21%. And another pathway I want to highlight is just soil. We were able to look at the amount of time that children spent on unimproved versus improved flooring. So improved flooring would be essentially anything that's not soil, dirt, or mud. And so we find that the time spent on improved flooring decreases as children age and as they spend more time in the courtyard versus the house. Going back to our pathways, just wanted to pull out some facts about our drinking water. So I just want to remind you that we found that stored water was more contaminated than source water, suggesting that water is being contaminated with E. coli after collection. In our data set, the median water age was about 10 hours. In the vast majority of cases, water was stored in jerry cans on the ground indoors. For hand transmission, I also just wanted to remind you that only 4% of the households we surveyed had any type of hand washing facilities. So hand washing is very limited in this area. And then finally, for fomite transmission, we saw that kids were mouthing a lot of household objects, which they were often picking up from the ground. And then you'll notice that I've discussed a lot of these pathways, but something that we haven't discussed so far is animal feces. And so we haven't spent a lot of time discussing this because we plan to measure all of a wide range of pathogens in animal feces, but that isn't complete yet, so we're not able to present those results. But what I thought would be interesting is just to see what the current animal ownership and animal feces sanitation practices were in these households. So just a reminder that 86% of households reported owning livestock. In 77% of households, caregivers reported that animals entered the physical home, and in 35%, animals entered the sleeping area. We also asked respondents how they disposed of animal feces present in their compound. And so we saw that 26% of households reported that they tossed animal feces into the bush or field, 19 that they tossed animal feces into the garbage, and another 10 said that no feces were ever present in their compound. So altogether, about half of the households report that there either was no animal feces or that they get rid of animal feces. But what's interesting is that this does not align with what we observed in the field. So our enumerators observed animal feces in the courtyard of nearly every household. And in 20% of those, there was even more than one type of animal feces present. We also asked caregivers a few questions to try to understand their risk perceptions. So we asked, how likely is your child to get diarrhea after contacting chicken feces, soil, human stool, or their own hand? And they could answer a range from very likely to very unlikely. So what we see when looking at this data is that fairly uniformly, caregivers perceive soil as likely to give their child diarrhea and human stool, but less so chicken feces. So it is perceived as a less risky pathway in this setting. And so I'll transition it back to Mboya to discuss our recommendations.
Thank you very much, Abby.
And Mboya, just a quick time check. If you could wrap up in the next 5 minutes, that would be fantastic.
Okay, thanks. Thank you, Abby. So I'll go over to the recommendations and what are the potential interventions that we could put in place or think about to disrupt these pathways that are predominant, as Abby has mentioned. So one of the first recommendations we have here is to conduct focus group discussion with community members to determine the best interventions. There are some money. Okay, yes. So based on the priority of the predominant pathways, we have classified this into the classes of the pathways depending on which one is high priority. So the first one, given that we had food, so one of the first intervention is food hygiene and safety. And the idea here is to engage community health volunteers on how to improve food hygiene among the community members or the caregivers. And some of the small key points here is just on the stored food, ensuring that the stored food is sealed, and then fully prepare or fully cook food and reheat before serving. And then boil, clean utensils and surfaces, especially utensils that are used for complementary feeding. And then drying racks for utensils can be locally made, which I think are locally available. So this, I think, could easily be done by CHVs and working with the caregivers to make this to be sustainable within the local communities. And based on what Mark also, the first slide that Mark presented, we look at the role of government. Just apart from the community system and the household, there's also a role that the government can play in terms of policy. Otherwise, we might burden the caregiver or the household in some of these interventions. Next. Yeah, the second intervention here is child hand hygiene. And we think here that exploring methods, the easiest methods for caregivers to wash child hands could really help in disrupting the pathways here. And then enabling the environment for hand washing, creating probably availing soap and water to do this could also help. And given this arid and semi-arid areas, and we had initially said water, access to water and sanitation is less than 5%, as much as caregivers can also play a role here, I think the government could also play a role and other stakeholders and NGOs in availing water for hygiene and sanitation. Next. The next is drinking water, and we think that exploring best strategies for chlorinating water in these setups could help in reducing these pathways. And some of the partners we have here is Evidence Action, I think, that has been doing a lot of chlorination intervention in Kenya, could easily come in handy if we have, if we adopt the multi-sectoral approach. Next. Yeah, as we had seen, like animal fecal route transmission pathway was also key here. We also think that we need to get input from the community members on the potential strategies for keeping animals, or just to see how they could improve or modify the animal husbandry practices with given their pastoralist, and livestock is also a source of income and as well as food for their families. So this also, we could involve caregivers as well as the head of household, which here I think mostly are men. So apart from just the female caregivers, men could also come in handy here, as well as the government through the Ministry of Agriculture, Ministry of Public Health, and probably Ministry of Livestock, just to improve these animal husbandry practices. Next. Yeah, we want to emphasize that results here are preliminary and may change after our further analysis. We'll go to conclusions. So based on what we have presented there, we could see like multiple pathways are important in the exposure of these children to E. coli. And the high diarrheal illnesses in youngest age groups with lower E. coli exposure is still important to interrupt transmission among these age groups. And then community inputs when designing programs are needed, or improved infrastructure by probably the government and the stakeholders could also help in getting sustainable interventions to disrupt this pathway. The other conclusion we think is engaging government to explore options for community level infrastructure or services that could sustain these interventions within the lower context. Thank you. And to acknowledge, we want to say thank you from the ProWash team, then our research team here, Amy, Angela, Dr. Jenga, our team from APHRC, and the rest of the Nawiri team. Thank you.
Thank you, Lomanito, John Mboya, and Abby for the presentation. We do have some questions coming into the chat, so I'll just start running through them in the 10 or 15 minutes that we have remaining. First one is, did you look at the routes for food, like via spoon, bowl, raw food, cook's hands?
No, so we were not able to test all of these routes. We just have the food samples themselves, but we did collect some more qualitative data on what kind of utensils and dishes that they used and whether those appeared clean.
Thank you. Did the research team assess the caregiver perception on child feces and their impact on the health of children?
No, that's not something that we asked about. I think that's an interesting question, and it would have been valuable to ask that perhaps, but no, we didn't include that in our caregiver risk perceptions.
Do you guys have any insights on why households in Samburu seem to be more contaminated than those in Turkana?
Sure. So first of all, I want to just, Amy and Angela, if you want to answer any of these questions, just feel free to jump in if you're able. I I think one reason for we may have seen more contamination in Samburu than in Turkana is that Turkana was much, much drier. And that may have affected the persistence of E. coli and made it less likely to be detected in our samples.
Great. The next one is around, well, there's a few around chlorination. One, is chlorination specifically an intervention that you recommend, or is it just around general household treatment options? And is it also a recommendation to promote safe storage or just treatment?
Amy or Angela, do you want to answer that?
Sure. Yeah, I think that for all of these recommendations, we do think it'll be important to engage with the community to understand what might be the best interventions or program or infrastructure to pilot in the future. I think one reason why we suggested thinking about chlorination is that it has the ability to be implemented in a lot of different ways, including through passive chlorination and automating chlorination, so to avoid burdening caregivers with having to treat their own water. And it also provides a residual so that if you're storing water, then it's going to be more likely to be protected against future recontamination. But of course, safe storage is also important. It's just that a lot of times safe storage doesn't take you all the way to getting to clean water. Okay. Yeah, so I can let others chime in.
Thank you, Amy. There was also a related comment in the chat about what is the county's strategy to chlorinate water at source for rural communities? That was partially, I think, answered in the chat. But if there are any other comments the team would like to make in response, please do. And if not, I'll move on. On the topic of child hand washing, it was noted that washing infant and young children's hands is not currently recommended because the wet hands might pick up more soil and pathogens. The question is, do you guys have any research to the contrary, or is this also your understanding of the current state of research and the risks for children?
Well, I think that's a great point. And I think that this is just an area that hasn't been researched very much. And so we think that the results of this study kind of point to more work to be done to understand how to keep child's hands cleaner, particularly in these types of environments that are lacking piped water supply at the home and potentially lacking dry surfaces to dry hands. So I think it's just an area that needs more attention.
One question that came through is, how did you guys define diarrhea for this study?
Yeah, I'll answer. So we actually asked 3 different questions with 3 different definitions of diarrhea to understand diarrhea prevalence. So the first was just asking, has your child had diarrhea, and relying on the caregiver's own perception of diarrhea. The second was having, I believe, 3 or more watery stools in the past 24 hours. And then the third, I'm not remembering the third right now, but we asked in 3 different ways. And so what I've presented today is actually the caregiver defined diarrhea, which actually was the lowest prevalence.
Great, thanks. And then another question was, when you were referring to environmental samples generally, what was encompassed in that term, like which types of samples?
That would
So
be,
for this,
go for it, Mboya.
yeah, for this, what we collected here was, one of them was soil, and this we collected at the doorstep where they get into the household. Then the other environmental sample was source water. And then we also got the formite, as well as any animals, fresh animal sample that was within the compound. It might not be complete with additional environmental samples, but we thought these ones would be better to collect with the limited available resources and measure what's the level of E. coli contamination here.
Thank you. I think we can take a few more questions. They're still coming in. Are there any plans to look at Giardia or crypto in environmental sampling, including water? This person said, I agree, chlorine seems to be the most easily scaled water treatment approach, but also concerned about oocyst risk given the % of households with livestock.
Yeah, absolutely. Yeah, go ahead, Abby.
I was just going to say, yeah, we're currently in the process of testing all of the samples for 30 plus pathogens. So that includes Giardia, crypto, and then a range of other pathogens, including like norovirus, specific pathogenic E. coli. So we'll have a wide range of data on specific pathogens.
And we will use that data to refine these recommendations for what types of water treatment might be the best for this setting.
Thanks. Any plans to look at environmental enteric dysfunction?
No, not in this study, but we will be analyzing the child stool samples for the pathogens as well. And we will have some longitudinal data to understand kind of very early exposure for these children and through which pathways that exposure is coming from.
One last question. As an exposure pathway, how significant do you think E. coli's role plays in the level of diarrhea for children under 6 months, as the daily dose rates were very low?
Yeah, I can take that. I think it's a great observation, and it's something that we've thought a lot about. And you know, this age range between 3 to 6 months is when children's exposure pathways kind of change dramatically as they start moving around more. They start putting more other types of things in their mouth, and some even start to consume food. And so we think this window is probably quite important, where they're getting a lot of new exposures. And so that potentially has an impact on whether or not they actually develop diarrhea. And so it's going to be really interesting to look at the pathogen results and see how those compare to the E. coli exposure data that we presented today.
Thanks, Amy. And thanks to the full research team for answering that long list of questions. We appreciate it. I wanted to highlight before we close that, as I said at the beginning of the webinar, this is the second webinar in a series of 3. In our first webinar, we presented results with our research and project colleagues on a similar study done in Madagascar. And in the next webinar, which is on December 6th, we're going to bring together the research and project teams from both studies to have a more in-depth discussion about how projects can apply the results of these research studies and how the results contribute to the global understanding of environmental risks for children. So if you're interested in that, you can sign up. I think my colleague just posted the link in the chat. And thank you all for joining today. Have a great rest of your day or evening. And this concludes the webinar.